this is now, of course, assumption, but I could imagine omalizumab could be an option, and this is the safest and best treatment for now, which we have licensed for chronic spontaneous urticaria, but we also have many like clinical trials and also case studies and systematic reviews showing that omalizumab is quite effective in cases of cold urticaria. So yes, if we stay on this path of histamine-mediated cold urticaria, then this could be the next option after 4-fold doses of antihistamine if they don't work.
Hello, everybody. Once again, we've got a podcast for you. And actually, this one is really exciting because we will talk about cold-induced problems. And actually, I just had a patient with me who reported, why always getting into cold wind, but only getting into cold wind. He and his mother had the same problems. Suddenly, these itchy wheals occurred. And then I had the idea, well, this time we make it really live. I'm just going to call Hanna Bonnekoh, our associate professor here at Charité, and she's really into the subject. So let's try if I can get her. Let's try. Phone is ringing. Hanna, are you there?
Hi, Torsten.
I hope the connection will work. I hope they promise you I would call you about a cold urticaria patient. And people listening to us, well, they know about cold urticaria, but there are special subtypes, and that's really funny. Now, I tell you, the one I want to discuss with you, a young man and his mother both have the same problem. When they go out and the wind starts getting stronger, they get wheals, especially on the lower legs and arms when the wind is coming there. What do you think? What is that?
Yeah, Torsten. So thank you for calling me and asking for my ideas. That's great. So I think this is a very interesting case, and we have to go a little bit deeper, especially because you're telling me that his mother is also affected. This is always a hint for maybe a familial disease, which is showing with those symptoms. And I also would like to know whether those skin symptoms are only wind-induced, or are there any other triggers which can induce the wheals, like direct cold contact? There any?
You can imagine, Hanna, what did I do? I used our TempTest. TempTest, for everybody listening now, is the perfect device. It's a so-called Peltier element. It's a kind of line in a circle which has different temperatures, starting from 42 degrees plus, so really warm, until 4 degrees Celsius, really cold. And it replaces the ice cube test for cold urticaria, contact cold urticaria, and gives us a real threshold, because we want to treat the patients. We want to see how does the threshold get better. We also want to see, well, how can we advise the patients? And it's always the skin temperature which is relevant. So I did the TempTest. It was negative.
It was negative. Yeah, great. So so then we know, okay, this is no typical cold urticaria. So we would say this is a kind of atypical cold urticaria, which we are dealing here. And yeah, there are different mechanisms behind this atypical cold urticaria forms. And that's why I would also ask, did they get antihistamines in the past? And did it work?
Well, they did get antihistamines, but only single dose for the allergic rhinitis. And they said, well, no, but it's difficult to say, they said, because it really depends. Sometimes if there's mild wind, it doesn't really matter. If the wind gets stronger and outside gets colder, and I think that's the so-called wind chill temperature, then it doesn't work. So that's what I asked them. So maybe a little bit, but not really well. But they only use single dose.
Yeah, so single dose. Okay, so of course we would recommend, based on our algorithm, to updose and try higher doses of antihistamine if we suspect that it could be a mast cell mediated histamine dependent mechanism. But there are also other types of cold urticaria which are not histamine mediated, which are, for example, interleukin-1 mediated. And this is something what I'm thinking of if you're telling me that there is a positive family history. But in those cases, I would also ask, are there other cold-induced systemic symptoms which the patient or the mother report? For example, like bone pain or joint pain? Do they have like fever? Do they report that they have difficulty hearing or also seeing?
I know what you're aiming at. So you're thinking of something like Muckle-Wells-syndrome.
For
And
example,
no, in this case not. But we should discuss Muckle-Wells, certainly important issue. But in this case, the wheals are normal wheals, short standing. Asked them, it was well, it's still cold here in Berlin, so I asked them to stand outside, and luckily it was windy when I met them. But the point is, these wheals were these classical wheals, short duration and nothing long-standing like in Muckle-Wells. So let's discuss this further. So you say we should go high antihistamine and then maybe the algorithm, but that's off-label omalizumab, or what else off-label treatment would you recommend in this case? So it's rather familial cold urticaria apparently with wind-induced
yeah.
cold air.
Yeah, that's a good point regarding the treatment options. Of course, I would start with antihistamines. And as you told me that they're also suffering from allergic rhinitis, I would assume the total IgE could be elevated. And from the chronic spontaneous urticaria patients, we very well know from the autoallergic phenotype, we know that omalizumab is working. So I would, this is now, of course, assumption, but I could imagine omalizumab could be an option, and this is the safest and best treatment for now, which we have licensed for chronic spontaneous urticaria, but we also have many like clinical trials and also case studies and systematic reviews showing that omalizumab is quite effective in cases of cold urticaria. So yes, if we stay on this path of histamine-mediated cold urticaria, then this could be the next option after 4-fold doses of antihistamine if they don't work. Sure.
Okay, what about the trials? Well, we acknowledge all trials in chronic inducible urticaria, in cold urticaria is cold contact urticaria. This is the rare case of a familial cold urticaria, wind-induced. But the question is, in cold urticaria in general, there are other possibilities off-label. What do you think about dupilumab in this case? Because also the rhinitis would profit from that. Okay, omalizumab, also the rhinitis would profit.
Yeah. Yeah, sure. So you mentioned that currently the clinical trials are ongoing in the classical, typical cold contact urticaria. However, this is an unmet need, those patients. Yeah, this is clear. So of course we need treatments for those atypical forms as well. So this would be also very interesting to go deeper into those more rare phenotypes and different phenotypes of cold urticaria. And dupilumab, of course, as you mentioned, could be very interesting. I wouldn't go for the old treatments for cyclosporin. I'm generation antibody, I would say. so generation targeted treatment. So I would be careful with cyclosporin. But yeah, so right now, we have great trials with barzolvolimab and also brinquilumab, which are like mast cell directed treatments targeting KIT and leading to a depletion of mast cells. And we could see, especially for barzolvolimab, that this was very effective in reducing the clinical symptoms. So of course, this could be also a good treatment option in patients with atypical forms of cold urticaria. Yes.
Truly interesting. What's on the horizon? Truly interesting for all mast cell mediated diseases. So for our listeners, barzolvolimab is an antibody against the CKIT molecule. CKIT is the one which is the SCF stem cell factor. CKIT is the receptor for that, and that is needed for mast cell survival. So if you deprive that signal for the mast cells, they really go into apoptosis. And that, of course, is a very radical but very efficient way to stop mast cell associated diseases. And luckily, it's a very safe molecule, and we are really, really looking forward getting it into our hands in treatment. But I think it will be another 2 years. Phase 3 trials are running. Hanna, that's correct?
That's correct.
Yeah. Okay. So
Right
we have
now,
to wait
also
a
at
bit.
our
And
study center. Yeah.
okay, good. But switch over. You mentioned Muckle-Wells, and
Yeah.
that's definitely not histamine. I think you should. It's your disease. Tell us about it.
Yeah. So I would ask also, often those patients don't really report the itch, they report burning. So of course we could also ask, what's the sensation? What do the patients report? Is it rather like itchy or pruritus sensation, or is this also like burning or even pain of the skin, what they reported to you? So this is another question we would ask if we would go into the direction cryopyrin-associated periodic syndrome. And you mentioned Muckle-Wells syndrome, which is a subtype of this clinical spectrum. Patients are presenting with those familial cold urticaria and also cold-induced systemic symptoms. And this is very interesting because, as I've already mentioned, it's interleukin-1, which is the main mediator of this disease and inducing those clinical symptoms. And this is based on a mutation in the NLRP gene. This is the gene which encodes for the NLRP3 inflammasome protein. And this is a very interesting complex which forms NLRP3 together with other proteins, resulting in, so this mutation results in an overactivation of this proteins, this inflammasome, which then produces, more interleukin-1 than in a normal condition. And those patients really profit from IL-1 blockade. And the good.
May I interject one question
sure.
for everybody listening here? When normally does the body produce IL-1? There are certain conditions why IL-1 is necessary. In which conditions? If you can tell us a bit more about that.
Yeah, sure, Torsten. This is very important. IL-1 is really necessary in the case of infections, because so somehow it also protects us a little from infections. And it's very important to know that, for example, like bacterial infections, but in some cases also some viral infections, part of the innate immune system, the interleukin-1 and the cells which produces are neutrophils, macrophages, peripheral blood monocytes, which produce this cytokine. In the case of infections, very important. That's also something what we have to detect before. So before starting such a blockade of interleukin-1 in those patients, we have to test for infections, for hepatitis, for tuberculosis, for example. So this is a very important topic. Thank you very much for raising this.
Actually, so for everybody listening to us, if you suddenly get the feeling of you getting fever yourself, you may start having an infection somewhere, even with the common cold, IL-1 will be raised. And that is the feeling which our patients with these familial cold symptoms also have. They have this feeling of getting fever because IL-1 is so much in the body. Luckily, there's also a very easy, cheap way in the lab test. Because with IL-1, something always goes up. Hanna, what's the easiest lab test to do? You can't do IL-1 analysis everywhere, but what you can do everywhere is.
Yeah, so of course you can assess the C-reactive protein in the blood. And nicely, or you could also do like a erythrocyte sedimentation rate. This is even probably a little cheaper, but most people do
The cheapest. You can do it everywhere in the world, which is great.
Yeah, you're right. So and the great thing is these basic markers are also implemented in the urticaria guideline. So basically every patient with a chronic urticaria condition should get those tests. And if those tests are elevated, the ESR is elevated or the CRP is elevated, then of course we should think of differential diagnosis of chronic spontaneous urticaria. Yeah, very important marker, very easy marker, cheap marker. But for those conditions, for the cryopyrin-associated periodic syndrome and other autoinflammatory diseases, we also have some special markers like the serum amyloid A and the S100A89 proteins. Yeah, these are specific proteins for disease activity and disease course. So they can also be assessed, but of course, basic would be the CRP is.
And amyloid is actually really the one thing which causes the deafness in our patients. So we really need to do something that amyloid doesn't block the physiological functions in our patients.
Yeah, this is a very, very important thing because there are single patients which also suffer from renal amyloidosis. And this is really a huge problem, very burdensome because, impaired renal function can result in hemodialysis. And this is something, of course, which we have to protect our patients. So there is a huge impact of identifying those patients and giving them the targeted treatment.
Yeah. Okay. I think we should switch over to some other rare forms of cold-induced urticarial. But no. One last question. I think what's also important, if you have a patient with a familial cold-induced or familial fever, autoinflammatory reaction, sorry, the wheals are different. They look different. They are longer standing and more dark. And I think that is one thing to really overall in all our patients with urticaria, we have no good guidance, but still we should look at what the wheal looks like and how quickly it disappears. Again, that gives us a background information about pathophysiological processes involved. Leukocyte influx will always lead to a longer standing wheal, and the normal, ordinary wheal that goes away often very quickly. Very, very quickly it goes away in cholinergic urticaria. You all know cholinergic urticaria, very frequent young adults when they do sports, when they do go for a hot shower, the increase of the body core temperature leads to these pinpoint sized small wheals. 20 minutes later, everything is gone again, but that's it.
Yeah, it's a very, very
Now,
important topic
can you
what you're
please,
raising. Yeah, yeah, because I also would
yeah,
like to add that
because there's
there's,
something curious with code.
yeah, and I would like to add that there's, the cold. So in doubt, also take a skin biopsy because you see those cells, those neutrophils. You can see them in the skin biopsy. And in patients with autoinflammatory diseases, they also sometimes perform net-like structures. This is something which we also observed and reported in the literature. So yeah, so take a skin biopsy if you are in doubt.
Okay, but I wanted something else. We have these many, approximately 11% of the young adults have this cholinergic urticaria, mild forms often. But there are some where it's cold-induced. Can you tell us about cold-induced cholinergic? It's a wonderful disease. No, well, not for those having it, but it's interesting. I can't even imagine the pathophysiology.
Yeah, that's very, very many open question regarding this phenotype of cold-dependent exercise-induced urticaria. So you have to imagine that patients need both trigger factors to get wheals. So exercising and cold temperatures lead to those symptoms. And Torsten, I think we don't have any care project specifically in this direction or any initiatives. So we are starting now to analyze the cure data regarding cold urticaria. So we started with a proposal and now I'm working on a data analysis of all the available cold urticaria patients in the cure registry. But so there's little evidence regarding this disease. I find it very interesting, but I don't know a lot about it. So do you know more?
Honestly, I've had very few cases, but that is actually the perfect closing words. We need to do more research. And it's we means everybody listening to us. You can all contribute. You can join in with the Cruise app if you're a patient. You can tell your patients if you're a doctor, use the Cruise app or join in with one of our UCare centers worldwide, attach to them, help getting patient data into our registries. There is so much more we can learn. We want to learn. We stay curious and we stay tuned in and will keep on doing these podcasts and informing you all out there about the news in our scientific development. So there's a lot more to come. Stay with us. For today, I can only say, Hanna, it was great. Thank you for answering the phone as expected, of course, always. And well, say bye-bye to all our listeners, Hanna.
Yeah, Torsten, was a great to talk to you. So, and yeah, we are also very open. So if patients listen to us, come to us. So visit us at our clinic. We will help you. I think it's also very important to show that we are active and we want to help. So any case is invited in our outpatient clinic, especially with cold urticaria, of course. Yeah. So
Okay, and go for the Galen website. Check out if you're somewhere not by chance close to Berlin. We've got centers all over the world who are there to help you if you're a patient, who are there to join in if you're a doctor. Stay with us. Thank you very much for listening and have a great day wherever you are.
bye bye.
Bye bye.